been great over the last few years to start to kind of make links with various charities and academics and people working in this space. And many of our members have kind of undertaken training sessions with doctors of the world and helped to educate doctors, healthcare workers around the issues, around access to healthcare. I won't go into full details. We'll hear more of that hopefully during the talks. We've also been on some marches and some protests with many of these groups like MedAct and Docs Not Cops, which have been a great way to engage in the space. And many of you maybe saw the campaign that we ran with MedAct last year, where around 20 humanitarian workers returned their medals that they'd been given for working in West Africa, in the Ebola outbreak there. They returned the government in protest against some of these issues. So we're proud to have helped to facilitate that, and that got really kind of broad coverage in the media and also a good political response as well. And actually following on from that, we've seen much more kind of interest, particularly in the medical sphere around it. So when we started looking at this, it was mostly civil societies who were making most of the noise and kind of and complaining about the issues that migrants and refugees are facing. Now we see that every medical Royal College and faculty in this country is now signed up to the same position, denouncing the charging regulations and the system which is in place, and calling for their suspension, for proper investigation, they are also endorsing the UCL Lancet Commission's key recommendations, which are really broad and kind of far-reaching actually, which is great, and calling for really a separation of healthcare and immigration enforcement. So there's been a lot of progress over the last 3 years, and it's been great to be part of the wider kind of civil society community looking and working on this. So if you want to get involved, let us know. We're always looking for more people to help us and kind of engage in these issues, and we also look at other issues such as mental health, and particularly mental health in detention centres. We've got a number of other things. If you want to have a chat about that at any point later, then come and grab me or Charlotte or anyone else who's going to take action. But I won't hold you any longer. On to the main events. So we've got, first up, we've got Dylan Demakuma, who is a public health and child and adolescent specialist doctor, who is one of the lead commissioners from the UCL Lancet Commission, which was released back in December last year. It was December, wasn't it? As a kind of nerd in this area, I was very excited when I got my copy and read almost all of it. It's quite long, but it's great. It's a really great overview of kind of everything that relates to migration and health. A really good synthesis of the evidence and over a really broad sector. So honoured to have Dylan here to kind of talk to us about his work and how it relates to migrant issues here in the UK. Cool. Thanks, Dylan.
Thank you for inviting me back. I've actually never been to this office. I was last in MSF about just over 10 years ago, so it's been quite a long time. I worked in Myanmar, South Sudan, Pakistan, just over 10 years ago with MSF as a field doctor. As Rob said, I'm Associate Professor in Child and Adolescent Health based in the Institute of Global Health in UCL. It's just about a mile away from here. And I'm going to talk to you about the UCL Lancet Commission on Migration and Health. So migration is a reality. People have always moved since the dawn of the human race, moving across Africa, out of Africa. And there's about 1 billion people, so about 1 in 7 people in the world are migrants themselves. That is, they were born in a different place to where they live. But what has changed is there's increasingly divisive political rhetoric that aims to demonise migrants and to separate them from us. And this is this kind of populist rhetoric promotes self-interest, and I'll come back to that in a moment. And we see that this discrimination against migrants leads to profound ill health in the migrants themselves in particular, especially mental health as well as physical health. But this affects everyone, so this affects the whole population. Studies from the US show that anti-migrant policies affected the local Latin American community and led to higher mortality, or at least was associated with higher mortality. In Australia, studies around racism and discrimination show an effect on the entire economy, a 3% decrease in gross domestic product over a 10-year period as a result of racism. So these effects that may target migrants affect everyone. And we see this kind of discourse commonly throughout the world. Our very own head of Brexit Party, Nigel Farage, holding back and taking back control against the migrants coming here, and also giving £350 million to the NHS every week. And we see Donald Trump famously talking about the caravan of diseases coming from Mexico into the US across the border. And I think the worst, Jair Bolsonaro, the president of Brazil, who described people from Syria, Bolivia, Iran as the scum of the world and their children coming to Brazil. And this is used, this is everywhere. Eastern Europe, Viktor Orban, for example, has these very anti-migrant, pro-white policies. But also in conjunction with this, we see a huge amount of policies that have been developing right back from the Second World War and the start of the World Health Organization. But this gathered steam recently with the WHO meeting in 2008, and then in 2016 the development of the Global Compact for Migration. And I'll come back to that at the end of the presentation. So in this context, we started the UCL London Commission on Migration and Health in 2016, led by Professor Ibrahim Abubakar, the head of the Institute of Global Health at UCL, and our team in UCL at the top there. But there were commissioners from around the world, 46 authors in all that contributed to this commission report, covering all kinds of topic areas: sociology, politics, economics, law, as well as the health fields. And our main aims were to provide the evidence around migration and health, to examine the multi-sector determinants of health and how they interact, critically review some of the challenges, and examine equity issues, and then importantly move forward. How does this evidence contribute to improving health in the UK and across the world? So I'll start with something that may be obvious to all of you, but migration isn't about moving from origin to destination. Usually it's moving from origin to somewhere in between, getting stuck there for some hours, some days, years or decades sometimes in that interim phase. Sometimes moving on to the destination, but then moving back to the origin, or getting round and back the other way. And increasingly circular migration, particularly for work, is becoming more and more common. People move somewhere, then stay for some time, move back, and move again. And this migration cycle is increasingly the norm. And the effects on health are in all parts of this. In the interim journeys and where people get stuck, the detention centres, for example, as well as the destination and origin. So one thing we aimed to do in this commission was to tackle some of the myths around migration and health. The things that are popularly said in political discourse, for example. And I'll go through those in turn through this presentation. What we see is that migrants are more likely to be contributors to economies, and I'll come back to that in a moment. If we look overall across the world, there are 258 million migrants in the world, international migrants that is, and they account for 3.4% of the world's population. Comparing to 1990, it was 2.9%. So there has been an increase, but actually a pretty small increase. There's been a 0.5% increase of migration over that time period. But these numbers are dwarfed by the number of internal migrants. About 3 times as many people move within borders. Classically, rural to urban migration in countries like China, for example. Of the international migrants, the majority move for work. They are labour migrants. The proportion of refugees or internally displaced people is much smaller. There's about 25 million refugees.
Good. We're good. Carry on.
Sorry.
Thanks for the little pause there.
So focusing on refugee numbers in particular, data from the UNHCR, we do see a spike recently in migration numbers, but actually comparing to 1990, not very different. And I guess this relates to particular conflicts that happened. So I guess, Syria most recently, and the millions of migrants that move across the border to Turkey, to Lebanon. Are they coming here and having lots of babies? Fertility rates higher amongst migrant populations? Okay. A large study from Europe compared fertility rates in 6 European countries and found that the total fertility rate for migrants was below 2.1 per woman. So that's the replacement rate for a population, 2.1. The only exception was women who come from Turkey, but across the board, fertility rates were actually lower than the usual replacement rate for migrants. So they're not coming here having more babies. So this is contraception rates, and we see higher contraception rates among migrant populations in this study, for example. Are migrants a burden on services? So we would argue that migrants actually contribute positively to services, that there is a brain gain in the destination populations. Particularly looking at the UK, 37% of doctors gain their qualification from other countries. And the UK is an importer of medical doctors, and this is mirrored in other health professionals in the NHS as well. Migrants contribute more to health services than they take out from them. Are migrants damaging our economies? So again, focusing on high-income countries, each 1% increase in the adult migrant population increases the gross domestic product by 2% with this. And this, if we look at the net flow of aid back to low middle income countries, official development assistance is around $150 billion. This is there's about 3 times as much in remittances that go back from migrant populations to low middle income countries. That's not to high income countries. So going back to Donald Trump's statement, are migrants disease carriers and pose risks to resident populations? Migrants themselves may be at risk of infectious diseases in particular, but we find that they're not, the resident population, the local population, is not at the increased risk of getting any particular infectious diseases. So the migrants themselves, they may be at high risk of tuberculosis, for example, and there are some studies around this, but that's more in relation to the living conditions that they are in rather than any specific thing about the migrants themselves. So migrants don't pose a risk to the local population. This idea of the caravan of diseases is a myth. We looked, my colleague Rob Aldridge led a systematic review looking at mortality amongst migrants, and found, so this was covered 92 countries, mostly in high-income countries that were receiving migrants, and found that migrants had a lower mortality than the local population, 30% lower mortality. And this was similar amongst men and women. Amongst refugees, it was actually even lower. They had a 50% lower mortality. And amongst asylum seekers, there was no difference. So we see that migrants tend to be healthier. Usually they are the more healthy people who are able to migrate in the first place. And this was across most disease areas. If we look at the disease-specific mortality, the 2 exceptions were infectious diseases, so there was an increased risk amongst certain infectious diseases amongst the migrant population themselves, and also amongst external causes, and that's important. There were issues around violence, assault, there was high mortality in the migrant populations. Morbidity is a little more complicated. Morbidity varies a lot, and certain conditions tend to have a higher incidence amongst migrants, particularly mental health. And we see this for the affective disorders, depression, for example, but also schizophrenia, psychosis is high amongst migrant groups. Post-traumatic stress disorders, particularly high in refugee populations, but this does vary a lot. We see very high ranges from 0 to 99% for some of these studies. We then did a review, so one that I led, on children who were left behind. So what we wanted to do was look at migration in the whole, so not just the migrants themselves. So we looked at the studies looking at children of parents who had migrated mostly for work, and looked at illnesses amongst those children. And we found that nearly all the data comes from China, where rural to urban migration is very common. And we found increases in particularly mental health and malnutrition amongst the children of the migrants themselves, which was contrary to what you'd think. Usually the children or the families that are left behind tend to be better off because the migrants send back money. But those children and adolescents seem to be suffering from higher rates of mental illness and malnutrition. But it should be said that the data from outside China is very scarce. We don't really know what the picture is outside of China. And this is just a harvest plot showing the evidence. So most of the studies showed on the left-hand side a higher risk for the conditions as we on the left. So then we looked at denying entry to migrants on the ground of public health protection, and we found that this was not supported by evidence. Health restrictions in states increasingly treating unauthorised border crossings as a criminal offence, and one thing we stand by is that migrants or migration, this is not illegal. Restrictions based on this is impermissible in terms of health and human rights grounds. We did looking at HIV in particular, we found that 35 countries imposed travel restrictions on people with HIV and 5 bar entry to people who are HIV positive. And linking health to migration enforcement, as we've seen in the UK, enforces distrust amongst the population and is a disincentive to seek healthcare. Mobile populations are often met with punitive policies, and we see this in many countries around the world. Many of the richest countries, the US, Australia, use these detention policies partly as a deterrent to stop people coming to their countries. And we see that this, maybe I have to talk more about this, but we looked at some of the international laws around this and found that this was a violation of international law. And looking at the health consequences, a systematic review found increases in mental illness amongst those people who were detained, as you may guess. Further work by Juarez et al. Found that restrictive entry and integration policies were linked to poorer migrant health in high-income countries. And they were restrictive policies associated with poor health and restrictive integration policies in general regarding welfare, for example, increased the odds of poorer self-related health and mortality. Some work done by Doctors of the World and Dr. Rob Aldridge looking at access, particularly in Europe, and the European Observatory found that analysis of the UK data showed that migrants were more likely to have been denied asylum seekers were more likely to be denied NHS care than other patients. And people whose migration status was undocumented were substantially more likely to report not seeking healthcare due to fear of arrest than others. And some work we've done in the UK looking specifically at undocumented migrant children, so led by Dr. Neil Russell, who I guess is part of this group as well. So undocumented migrant children, there are around 120,000 in the UK, about half of whom were actually born in the UK, but their parents have an undocumented status. And these people lack the documentation proving a regular migration status. What we find that they have, when they seek healthcare, they have to pay upfront for charges, and this is above the normal tariff, 150% of the normal tariff. So they're paying more than a normal patient would pay in the UK. And some of these people, if their debts are not paid within, I think it's a 2-month period, they are referred to the Home Office. I'm sure you'll come to these types of issues much more. And this links back to their migration status. And this obviously has detrimental health on child health. Children will not be treated for conditions that they would normally be treated for. And this is within secondary care rather than primary care, I should say. And parents would delay taking their child to see the doctor. So any conditions would tend to worsen over time. So when they do present, it tends to be in a worse state. And importantly, antenatal care is not exempt from charging. And this, on average, is around £6,000 per delivery, let alone the complications or if the baby has to go to intensive care. And this seems completely at odds with the policies of the NHS about universal health coverage, the international policies that we have signed up to. And there are other safeguarding issues. Victims of modern slavery, survivors of modern slavery, are exempt, but we don't usually know who they are. And the hidden nature of some of these people means that they don't seek healthcare, we don't find out, and then they often get charged when they shouldn't be charged as well. So migrants' right to health. So we took two basic stances within the Commission, one on a human rights ground, that migrants have a right to health, and the other on health systems access argument. Migrants have the right to the highest attainable health, regardless of the circumstances of their migration or legal status. That's important. Universal health coverage is not about your legal status to be in the country. It covers everyone. The International Covenant on Economic, Social and Cultural Rights guarantee the right of everyone to the enjoyment of the highest attainable standard of physical and mental health. Again, this is not about migrants or non-migrants. Everyone should have access to the highest attainable standard of health. We would argue that the WHO targets for universal health coverage and targets within each country should include all people within that country, not just nationals or residents of the country. We argue that access to healthcare is health for all, and the health system should be constructed to be people-centred rather than based on national identities. So the key messages from our Commission report that Rob was mentioning earlier. So we call on nation states, multinational agencies, non-governmental organisations, civil society to positively and effectively address the health of migrants by improving leadership and accountability. We propose a migration and health observatory to develop and provide evidence-based migration and health indicators to improve reporting. National, international and regional bodies should rebalance policy making to provide a greater prominence to health. The initial Global Compact on Migration and Health, the initial version, didn't mention health at all. So in the many objectives that they had, health wasn't part of it. Health leaders and practitioners should focus and fully engage in dialogue on the macroeconomic forces that affect population movement. People usually don't want to move. People usually are forced to move to provide a better life for themselves and their families. We should tackle racism and prejudice with a zero-tolerance approach and oppose xenophobia and racism that fuels prejudice and exclusion of migrants. This is common. This is every day from the media. This is what we hear in the news from politicians, from all types of media. There's an anti-migrant bias, which was not acceptable if you replace those words with a black person or a Pakistani person or an Asian person, but it is okay when they talk about migrants. Universal and equitable access to health services should be provided for everyone. This is Louise Albert, who led the Global Compact for Safe, Orderly and Regular Migration. So promotes a well-being not only of migrants but of all communities in countries of origin, destination and transit. And I just want to mention a couple of things to finish with. Firstly, the Global Compact and then the WHO Global Action Plan to end with. So the Global Compact was first developed in 2016 in the New York Declaration. And then there was a 2-year process of discussion, deliberation, with a number of UN meetings on different aspects of migration. In December last year in Marrakesh, this was signed by 164 nations. It's important to say this is not legally binding, but at the end, a number of nations were pulling out, even though they aren't bound by what's in the compact. And if you have the time, it's worth just looking at the main objectives. Health is now a big part of the Global Compact. There's, and the UK has signed up to this, so the UK has endorsed the Global Compact on migration, supporting the health of migrants. This is some work that we did looking at child health specifically, and it's actually quite good. It endorses the UN Conventions on the Rights of the Child. The parties recognise the right of the child to enjoy the highest attainable standard of health, to facilities for treatment of illness and rehabilitation of health. State parties shall strive to ensure that no child is deprived of his or her right to such healthcare services. This is important. So the UK not providing healthcare for undocumented migrants, it's going against their own policies. It's going against UN Conventions on the Rights of the Child. It's going against Global Compact for Migration. And finally, the Global Action Plan for migrants and refugees. So these were the 6 priorities that they came up with. To reduce mortality and morbidity, to improve continuity and quality of care, mainstreaming to improve legal and social protection, well-being, gender equality and empowerment, to tackle social determinants of health, counter xenophobia, improve information health systems. This went to the World Health Assembly today, actually, and Professor Abu Bakr was speaking at the World Health Assembly today to try and encourage countries to endorse this statement. And I get to see exactly what's going to happen. Apparently the Americans weren't very happy. So there may be some backwards and forwards as to the language that's in this. But all these documents point towards improving health of migrants. And these documents that we can use going forward. So our conclusions. Migration and global health are both defining issues of our time, but how the world addresses human mobility will determine public health and social cohesion for decades to come. Migration should be urgently considered as a core determinant of health and well-being and a global priority for the 21st century. And we can make a difference, and we can improve the health of individuals who are most vulnerable and who are most at risk of being marginalised. And I'll just end with a quote from Dr. Jocelyn Park, who was our editor, and Dr. Richard Horton, the editor of the Lancet. The moment for migration is now. Migration is our reality and our future. It needs to unite rather than divide us. That's our commission that you can find in one of these links, and our commission is on the site. Thank you very much. Time for questions?
Absolutely, yeah. There's some questions. I'll start. Thanks, Colin. That's a fantastic overview of, obviously, not comprehensive look at the whole commission, but some really interesting, important points. So thank you for that. I guess for me, what the commission does well is it lays out the evidence, it shows the data, it demonstrates, clearly that migration is really mostly a very positive thing for our society, and particularly from a health point of view, many of the claims, the negative claims around it, which are made, aren't based in truthful facts. And I think, it sets that out really nicely. Having said that, something we have noticed when we've been doing kind of our work is that it seems that the public don't really care about the data or the facts. The fact, one thing that a lot of reviews have come out with is that maybe by restricting healthcare services, it's actually costing more because of the public health implications. People are getting more infections, they're not getting preventive care. So I guess what are your thoughts on how we can take this kind of knowledge and communicate better with the public and really try and take hold of the narrative somewhat?
No, I agree. Arguing about a 2% increase in gross domestic product doesn't matter usually. If your brother has lost a job to someone who's come to this country, that doesn't mean anything. Macroeconomic arguments are not very effective. And I agree that data is often not very effective as well. It tends to feed into narratives that reinforce what you believe already. So if you agree that migration is a good thing, you will take on board what you like from here and still agree that it's a good thing. If you don't, you dismiss it and you take the other arguments. And the thing is, there are 1 billion migrants. Everything happens, good things, bad things. Some people get unwell, some people are healthier. There's a whole mixture of things. So a lot of it is about these arguments, and framing these arguments in ways that people understand and that builds on their own knowledge and beliefs as well. So some things like the stories about if you go to the NHS, you're actually quite likely to be treated by migrants. It's not that they are taking your place here, but there are so many doctors, nurses, every person in the hospital, there are migrants. They are the backbone of the NHS. And some of those stories could be very powerful. There are ways and there are approaches, reframing approaches, where you build a story to help communicate what you want to. And marketing people and politicians, they do this very well. Nigel Farage is actually very good at this. He frames a story in a certain way that delivers the message he wants to. It's very effective. And there's a lot we can actually learn from people like that we can also frame it in a different way to give a positive spin. Migration is good for economies, it's good for business. Most businesses don't want to come to migration. They want the best people to work in their jobs. They want people who will do jobs that others won't do as well. So a lot of those stories we can give as well. I also think what you said about it costing more, denying access is not a good thing for the migrants themselves, certainly, but also for everyone else. Conditions tend to get more severe. The risk of transmission of an illness may increase, and it ends up costing more to the health system when someone comes in an emergency state, which is actually free from upfront charging. So there's benefits to giving free access to everyone. The costs are huge. The overseas managers, all these people that have to be in place to be able to implement charging. I mean, the reported figures are very small in what upfront charging will gain. I suspect that it won't gain anything, actually. I suspect that it's actually going to be an increased cost to implement these systems to take money from migrants. But I think there's a huge thing within the advocacy field about framing the stories, the narratives in a positive way, to bring out some of these facts and to take the commission, to take the data and then deliver it in the right messages. And there's a lot we can do that you guys can do to deliver those facts in the right way.
Within the UK or in any other international health systems, has it led to the adoption of any fairer policies when it concerns migrant health or refugee health and treatment?
Some things have changed. So, I mean, the Global Compact, the language within the Global Compact changed over the 2-year period. If you compare the start and the end document. And we contributed to the WHO Global Action Plan. So some of that language is actually very good and very useful, and we can use that going forward. It could be better, certainly, and looking at some of the amendments and objections by countries is very interesting to go down. But as a collaborative process, and what they ended up with is actually, I think, quite strong. So on an international level, that has changed over the last 2 years, certainly. On a national level, I think it's yet to be decided, and it depends very much on the government in question. I suspect certain, I mentioned Brazil, the US, others, they've taken a very anti-migrant stance, so I don't expect that to change very quickly. But there are certain things that you can get movement on. I think arguing about health of children, for example. There are things that, even the very right-wing populist governments would agree are good things. So improving child health across the board, covering the 120,000 people in this country, I think that's something that we can win on relatively easily. It would take some effort, I guess.
Can I just add to that a little bit? Of course, through your engagement through all these specialists around the world, there has been political engagement. Obviously, you put on a couple of all-party parliamentary groups meetings here in the UK, which has attracted kind of prominent politicians like David Lammy, Kate Green, Paul Williams, but there's also internationally as well. You know, with one of my other hats, I work at Chatham House, and we're working with Dylan's colleague Miriam, who's now one of the lead commissioners on, setting up kind of roundtable discussions to look at specific countries' policies, like in South Africa and some South American countries as well. So it's never going to happen like that, but I think your links and potential influence and connections are very strong here. It's a very kind of well-regarded commission.
I went to the launch of Kathmandu a few weeks ago, and there were people from the ministry there were all the big NGOs were there, and a lot of doctors, a lot of leading doctors were there at this launch, and they were very keen. So Nepalis, most of migrants sending huge populations go mostly to India, to the Middle East, and come back with various health issues. And they have pre-migration and post-migration health issues that those medical doctors are dealing with. So this is a big thing for them, and we were very keen to try and implement policy to improve the health of their population.
Any studies that show anything about herd immunity? It's just you lose a lot. If people are undocumented, I would think that kind of undermines your vaccination policy. And I just, in any of your statistics, I didn't see anything specific on that. I think it's very, when you talk about how to tell the story, it's a story that's out there.
Yeah. I don't know the studies personally. I guess as an argument, vaccination is something where you need regular input with the health system, and mobile populations don't have that. So partly just they don't have access to the health system where they are, but the movement also, the moving between immunisation regimens as well, which adds a complication. So I suspect there would be studies showing differences in immunisation rates. I don't know them off the top of my head, but I can get back to you on that.
One more question. Okay. Cool. Well done. Thank you very much. Really interesting talk, and very much appreciate your time here. So, next up, we have Sasha Rosansky. Sasha is a lawyer with Dayton Pierce Glynn. She specialises in public law, EU and human rights, and she uses a combination of these to try and secure life-saving hospital treatment for foreign nationals, and also social services support for migrants with physical disabilities or mental health, amongst various other things which I'm just going to talk to today. She's going to really be bringing something which I really don't know anything about, and I'm really excited to learn about, which is kind of the legal perspective on a lot of this. Because coming from a medical background, it's a terrifying, scary world, sort of, and hopefully she's going to enlighten us a bit around it. So thanks, Sasha.
Thank you. So I'm just going to give quite a brief overview on the charging regulations, because it can be a whole day's training course. So what I'm going to be talking about now is by no means very comprehensive. I'm just really focusing on quite specific aspects of the charging regime and how clinicians can try to help people who have been refused healthcare treatments to access that treatment. The primary healthcare currently is free for everybody, no matter what your immigration status is or how long you've been in the country. It's secondary healthcare where there is the charging regime. So within secondary healthcare treatment, there are exempt categories of treatment. So some particular types of treatments are exempt from being charged, so they'll be free for everybody as well. The examples are wider public health conditions, including HIV, tuberculosis, malaria, measles, whooping cough, etc. There is a longer list, but these are the more common ones. So it's worth having a look, checking that if someone's being charged or refused treatments, they can't afford to pay for it, whether that treatment is actually exempt from being charged. And then there are exempt categories of patients. So if you fall within this category, then you can't be charged. So people with EU rights, and that doesn't necessarily have to be an EU citizen. It might be that you have an enforceable EU right to live in the country based on your partner status. So you might be Brazilian married to a Spanish citizen, and so even though as a Brazilian you don't have you're not an EU citizen yourself, but if you're married and your partner is working, you have an enforceable EU right. And this can sometimes be a very complicated area. There are lots of appeals that go on to the Supreme Court of Appeal, arguing about whether someone has an EU right to live in the UK, and if they have that right, they would similarly be exempt from exempt category of person from charging. So it's very complicated, and not just and lots of these statuses sort of have. If you have a reciprocal healthcare agreement, I think probably we have. Reciprocal healthcare agreements in lots of different countries, Kosovo being one of them. If someone has temporary protection, refugee status or humanitarian protection, if you're an asylum seeker or if you're a person getting various types of asylum support, then you'll be an exempt category of patient and you can't be charged. But like I said, this could be a very complicated area of law, and it's the hospitals who be making the decisions about whether someone is exempt, and often the overseas payments officer won't have necessarily quite specialist immigration training about whether someone is arguably falling into one of these categories. So the main headings that I'm going to be focusing on then are whether treatment is urgent or whether it's immediately necessary, because if the treatment is, then it must be given, whether someone can afford to pay. And only clinicians can decide whether treatment should be classified as being urgent or immediately necessary. It's not for the overseas payment officers to make that decision, it is for the clinician to decide. The definitions are I think, quite straightforward from a legal perspective, but my difficulty is sometimes knowing whether or not from a clinical perspective, if someone's condition fits into these definitions. So immediately necessary treatment, and all this, I don't know if you're aware, there's guidance on implementing the overseas visitor charging regulations. It's quite long, I think it's about 120 pages, but it's quite easy to navigate, and it's got lots of nice helpful definitions and examples in it. So although it's very large, it is very accessible. So if treatment is considered to be immediately necessary, it's treatment which a patient needs promptly to save their life, or to prevent a condition from becoming immediately life-threatening, or to prevent permanent serious damage from occurring. So it's quite clear if treatment should be considered either any of those definitions, it must be given. Hospitals can't say, well, you need to pay. If it meets these conditions, it has to be provided regardless of someone's ability to pay, regardless of their immigration status. Treatment must not be delayed to establish chargeability status or obtain payment. So if there's a query about whether someone meets any of the definitions about being exempt patient, if treatment is needed for any of these reasons, it shouldn't be delayed while someone's trying to prove what their immigration status is. And just as an addition, that all maternity treatment is considered to be immediately necessary at whatever stage of the pregnancy. Treatment that's urgent is that what clinicians do not consider immediately necessary, as per the previous definition, but which nevertheless cannot wait until the person can be reasonably expected to leave the UK. And so, although it's a clinical decision about whether treatment is urgent, it's difficult for a clinician to know when a person can be expected to leave the UK. And so really, as a clinician, I think you should be asking the overseas officers, payment officers, when can this person be expected to leave the UK? And if you can't be given that information, you can't decide that the treatment is not urgent. So factors which was included in the guidance to consider about whether treatment is urgent, whether someone can reasonably wait to leave the UK to get the treatment is the pain and the disability that the condition is causing, risk of delay for that person to be able to return to their country, the likelihood of substantial and potentially life-threatening deterioration occurring if treatment is delayed until they return to their receiving country, and the estimated return date. And so again, people who don't work within the immigration field may not necessarily understand that there's going to be a delay in someone returning to their country. it's not as simple as just owning a British passport, buying a ticket, and getting on a plane. Depending on where you come from, there might be a lot of migrants come here without maybe on a false document. If they're coming here to seek asylum, they might have to be smuggled here, and so they don't necessarily have a passport. So to be able to return to their country isn't necessarily going to be an easy thing to do. Some people may have had their documents stolen, they may not have proof of their identity. Lots of countries don't have the same way of collecting records to be able to just go up to the embassy and say, can I have a passport? I need to go back to my country to have my medical treatment. There are certain countries where that just refuse to cooperate with the UK authorities. I mean, for example, it's very hard for somebody from Iran to be able to get a travel document to return back there, even if they have proof of ID. I mean, even someone from India, where I think they are quite good record systems, just because of the sheer volume of the High Commission, it can take 3 or 4 months for somebody to be able to get there, and even someone who's cooperating to return there, it could take a very long time for them to get a travel document to be able to return to that country. The question in that example is, as a clinician, you need to be told exactly how long it's going to take, or at least an estimate, to be able to return to their country, so that you know to give a clinical view and, well, what are the risks if that person does have to wait that long for the type of treatment that they need. So just expanding on that, so looking at whether it's reasonable for them to travel to their country of origin, so factors including difficulties of getting travel documents. Is someone well enough to travel? Do they have a pending application with the Home Office for some type of leave? Because if they do, it's unreasonable for them to have to travel while they're waiting for this application to be considered. Sometimes the person will say, and they've got proof they've made an application, but yet the Overseas Payment Officer will contact the Home Office and say there's nothing outstanding. So it's trying to resolve that conflict of information and get evidence and challenge what's the hospital's claiming about their status. I just wanted to give an example. Difficulties that a person can have about accessing treatment where it seems that it might be urgent or immediately necessary, and just the battles they're having to get that treatment. So I had a client recently who had a letter from a hospital from a doctor to say that if he did not receive dialysis within 3 months, he would die. So going back to the definition of immediately necessary, quite clearly, in my view, as a non-clinician, he would fall under that definition of treatment, that the treatment being immediately necessary. And that test is separate from the urgent test, whether he could return. He didn't have any travel documents, so arguably it was urgent and immediately necessary. So that letter was written at the end of December. I first saw him 6 weeks later, and he was being refused any treatment because the hospital said it's not immediately necessary. So he wrote to the hospital threatening legal action. Clearly, he'd got this letter saying he will die. Arguably, well, not arguably, no, it's clear that he meets the definition of immediately necessary. He needed the dialysis to save his life. And the hospital fought it very, very strongly. And we had a letter from the hospital solicitors saying that the clinical director and another leading nephrologist had reviewed the notes and said that the treatment wasn't immediately necessary. So it's very difficult from a legal perspective, the way to challenge it through judicial review. And the courts won't substitute in that sort of process, decision-making process and legal challenge, the court doesn't substitute its own decision, they'll look at the decision-making process. So if you've got 2 specialist senior doctors saying, no, it's not urgent, it's not immediately necessary, it doesn't need to save his life, it's very difficult to fight that. To challenge that. And so fortunately what I was able to do in that instance, I contacted, there are a couple of email groups, so I contacted one of the email groups just to put a post on it saying, if anyone knows a nephrologist who can help, I'll be really grateful, because it's just quite difficult to navigate the medical notes and what the actual evidence says. And a nephrologist did get in touch, and she was amazing. She went through all the notes, explained to me what things meant, what should be happening. She explained that with my client's particular blood test results, the ones that were now 6 weeks old, the results which would suggest that he probably did need dialysis urgently, very, very quickly, but it very much depends on his stability. So if he was deteriorating, he would need a treatment straight away, but if he'd been like that for quite a few years, on a longer term, it probably wasn't quite so urgent. But the difficulty was there had been no blood tests done for 6 weeks, and prior to that they were done, I think, 3 months earlier. And so the nephrologist I spoke to said, really, I mean, how can the clinical director decide what the current situation is without having current blood test results? So the independent doctor who I spoke to suggested that I advised my client to go to his GP to get current blood test results, which he did, got them back within a couple of days. I then spoke to the very helpful nephrologist again, and she said he needs dialysis now. I sent the results to the hospital solicitors, and within a couple of hours they said he needs to go to A&E. And it didn't matter that he was getting the treatment. But had I not been able to get in contact with a specialist, it would have been very difficult to challenge the decision. So I think these are just the difficulties we face, and I suppose for me, just as a human being, rather than as necessarily a lawyer, it was quite dispiriting and demoralising that senior doctors were able just to say, I'm not sure the reasons why they were being pressured or what the reasons were, but that they were able to say it's not urgent, it's not immediately necessary, without having a review of the clinical notes. So that kind of leads me on to what clinicians can do if you are met in a situation where a patient is being refused treatment. So I think just familiarise yourself with the rules on charging. I mean, I'm not saying go read the guidance, but just be aware of just those definitions I've mentioned already on immediate necessary and urgent treatment. It's, if you just Google NHS charging regulations guidance, it comes up at the top here, and you can then just do a find for the immediate necessary and urgent. So it's very easy. So if you're not sure, just look it up, and then just using that example, so ensure medical reviews. So if you are being met with circumstances where you're being asked, is the treatment this patient needs urgent or immediately necessary, then ensure that the reviews are up to date. So if you're given some notes that are out of date, then say, well, I can't make this decision because I haven't had this scan done or these blood tests carried out, whatever it is that needs to be done. And if actually if ordinarily the treatment would be given immediately rather than waiting for some more tests or scans, then you should be saying, well, we can't wait for this to be carried out. This needs to be given now. We can't, shouldn't review it any further. If the tests are up to date, but you think, well, the situation could change in a week's time, a month's time, 2 months' time, record it in their notes so it's clear, and try to communicate that to the patient as well, so they know when they should be reviewed if the situation can change. Ask the overseas payment officers when a patient is likely to leave the UK. There's a form which is on the government website. It's called a clinician patient assessment form. It's just an example. Hospitals don't actually have to use it, but move up here. So this is what should be given if this form is used. What should be given to the clinicians, and you see here the date that the patient can be reasonably expected to leave the UK should be completed, or even have the box ticked the patient cannot be expected to leave the UK for at least 6 months or at all. And only then, once you've got that information, should you as a clinician be able to tick one of the boxes further down saying, having made the appropriate diagnostic interventions, the treatment is immediately necessary or urgent or not urgent. Or even I must make further investigation before I can assess the urgency. I've seen an example where a hospital has this exact form, but these 2 lines have been removed. Date the patient leaving the UK, and so really I'm not sure how the clinician can actually make that decision about as to urgency if they're not provided with that information from the overseas payment officer. So if as a clinician you're asked to make an assessment as to urgency or necessary, you should be asking definitely when can the person leave the UK. And I think that you're making a clinical decision based on that information. So I think if the information doesn't look solid, or it looks like it might be changing, then ask for that, ask for more information there. And so you can be part of a network to give advice on your specialism. So there's Doctors of the World. I don't know if you have that sort of network at MSF or not, but there's with docs.com. So it's, I mean, I don't think you'll be inundated if you wanted just to, you know, there aren't a huge number. I mean, there probably are huge number of cases, but unfortunately, I think most of the patients just don't get legal advice. But if you are interested, it is worth getting in contact and just, you know, with one of these organisations to say, you know, if someone needs advice on this specialism, because that nephrologist was invaluable. You know, I don't think we'd been able to progress this case without her.
I mean, we're closely linked with all those groups and networks, so if anyone wants links to those, to come to us, we'd be very happy to link anyone up.
And then, you know, if you have a client yourself that's being refused and you feel that you can't help them get the treatment, then refer them to a lawyer. Very often we are referred patients from the private doctors. I think that's all. Brief overview.
Thank you, Sasha. Fascinating. And we've got some time for questions. Maybe we can start with some questions around Sasha's talk, and we've got till 8 o'clock, so we can even start to discuss issues a little bit more widely after that, if you like. Is there any questions? Alan?
Can I ask a question about when clinicians disagree with each other? So you had the nephrologists disagree. Can you take the opinion of the one that you want, or what is it, a balance of opinions, or how does it work?
It is difficult. So from a legal perspective, if the hospital has got their own clinicians' views, it's about whether the hospital's therefore then reasonable to have reached that decision. So it is difficult if you're going to have two opposing views. I mean, if you've got one view that's a lot more senior, then arguably that's going to be more important. But you know, I had a clinical director, so you can't really trump that, I suppose, from a legal point of view.
So you have to argue the case and show that your view is.
I think it would just be based. So I think the difficulty with in that case, the clinical director, we kept saying, give us the evidence that they've used to reach a decision, and they've refusing to do so. So if we can then come back with another doctor's views as to reviewing the evidence and say, well, based on ABC, it must be urgent because if not, X, Y, and Z will happen. Whereas the other is saying, we've reviewed it and this is what we decided without giving the reasons. And you know, failure to give reasons in judicial review claims is arguably unlawful, particularly in such an important matter. But I mean, I have an example where, so you might have heard this example at the last meeting you were at, but so I had a woman, very slight woman, who had a cancerous lump in her breast the size of a football, and she was referred by the SHO, and the hospital solicitors were arguing with me that it was only an SHO whose view was that the treatment needs to be given urgently. So, I mean, you know, again, they backed down immediately once they had more information about it. But yeah, but up until that point, she'd been in hospital for weeks and weeks and weeks. She had to have her wound, the dressing changed every few hours. There's no way she could even travelled. You know, she was Polish. She was an EU national, but she'd been homeless, didn't have proof of her passport. You know, so it's just this really horrific cases. But you know, I haven't had a case yet where the hospital hasn't backed down. But usually by the time they get to us, they are quite desperate cases.
Can I ask on what grounds are the hospitals turning around and arguing that a patient isn't eligible to receive treatment? Are they abiding by the kind of the national laws imposed by the overseas physician policies, or do they also have within their own organisations the right, as it were, to implement their own interpretation of the overseas countries' rules?
They should only be following the statutory regulations, charging regulations. But I think various hospitals may have, I mean, the law requires them to charge up front, so they do have to charge, but I suppose it's their own interpretation of what the definition is as to whether treatments are urgent or necessary.
So I was just wondering what are the financial pressures that are causing hospitals to push back? Do they, so if somebody does meet the criteria for treatment because it's urgent or necessary, presumably that must do they get some sort of treatment or medicine?
So I'm not sure if I've followed.
And can you repeat the question when?
Okay.
Sorry, the microphone's right next to you.
Sure.
So.
Would you mind? I'm not sure if I've followed. Sorry.
Yeah, sorry. So I was just wondering what are the financial pressures that cause hospitals to push back against this and argue the case that patients don't meet the criteria for
So the question was, what are the financial pressures that the hospitals are under and their reasons for refusing treatment?
Yeah.
I don't know if that might be something for research.
So I guess it's about NHS charging and NHS payments and how payments are routed. For an individual case, I guess if the hospital doesn't treat, they don't pay for that person. So the argument I was making is that the whole system is quite expensive. To have these overseas managers is quite expensive, so that's quite costly. But once you have that system, to not pay for a patient does save the money, save the hospital money. There's a reimbursement system in the UK, and the GPs or clinical commissioning groups pay hospitals for the patients, so there's a rotation of money, which is essentially all tax-based money. But if you take a single case, it would be cheaper for hospitals to treat that patient. But if you count all the lawyers' times, then I'm not sure if it is.
So on that, can I just follow up? Are there incentives or penalties in place? I mean, the NHS is fairly good at, if for instance you were at a hospital that had higher percentages of treating these people, would you end up in trouble? No?
Insofar as I manage a couple of surgical specialties within the NHS at the moment, and so I'm really interested in this particular field of international sort of health provision for migrant refugees, as the surgeons aren't always particularly confident with this, because there is I find within our own organisation a little bit of political pressure to implement some of these methods and changes and take advantage of the lack of understanding clinicians have regarding the rules specifically on what feels a bit like the basis of fear-mongering. Now, you're quite right within the NHS that a spell of care is somebody coming into hospital, for example, being referred outside into hospital, they receive their treatment and then they're discharged back to their local GP. And when a person comes into hospital, they're registered with a hospital number, and that number follows them through their episode of care. Given the administrative requirements of establishing, does that person have a home? Are they entitled to the refugee status, or indeed any of the other categories that you mentioned there? If I'm being really blunt about it, there's no way that the administrative systems of the hospital are well organised enough to ensure that a patient isn't billed for on the basis of the hospital not being registered under any of those categories. I think what I tend to see happening instead is almost like a proactive approach from the overseas team to identify those patients up front, so that then follows it through to the commissioner group. But I don't believe that from the commissioning side, unless a patient is identified to them as somebody not eligible for treatment, then they wouldn't then pay. So in other words, if you don't speak up, they won't be noticed, you'll still receive the income. So there isn't really a financial pressure associated with it, unless you then receive a challenge from the commissioning group as part of your planning phase, your budgetary phase, or end of the financial year, disputing if somebody deserved treatment. But equally, you can counter that with the numerous instances of data capture within the NHS that lead to finance is not being received, and I would argue that, or I would absolutely, I imagine could prove quite easily that the cost of an overseas individual, somebody from overseas receiving treatment within the NHS, that cost is easily offset by the numerous data errors of other patients that we should receive money as income for, we don't at all.
Can I also pick up on one of the points that I don't think clinicians really know the rules.
No, they don't.
So my wife is a clinical psychiatrist, and the overseas manager comes to her and says, this person has to pay, and she doesn't know. I mean, most clinicians don't know. So they do what they're told from these people and say, you've got to do this. And that's where this kind of stuff is very useful. Everyone should get taught this.
Sorry, just to follow up on those. So I think when we had the previous forum we were at, with what the clinicians were saying, that the training, unfortunately, isn't about raising awareness about how you can help people. It's more the training is given on how you should be stopping people from getting the treatment. And then just two other points from what you said. So there is now a legal requirement for a patient's overseas status to be recorded on their records, so that once someone has been identified, and that record should stay with them. But then a second point, well then if, I was in hospital a few weeks ago with my son, no one asked us for proof of our identification, and so there's going to be there's a large amount of discrimination going on here, because me and my son look the part, we look British, but what about other people who are British but don't necessarily look British? And there's no requirement that you have to take your passport or your driving licence to the hospital. And so the people who are being penalised, it's just this very racist regime we've got in place, really.
I think within the NHS, one of the biggest fears is that it will result in some other form of legal action against the clinician if they don't. It's that damned if you do, damned if you don't attitude that again, this ridiculous hostile environment seems to permeate, especially within the NHS. I can't identify where from, but have speculation within my own organisation of what's going on. And hearing something like this, it's particularly useful to then be able to take back, just so that as the group of surgeons that I work with are able to know where they stand and they can make their choice. I will support them if they choose not to identify somebody as being international versus if they do, and if they do, to know what their kind of medical legal obligation to that patient is.
So again, just in response to that, I think that touching on your research as well, that so there's why do people have this view that people should be excluded? I think there is a myth that we have a lot of health tourists, and I'm not going to deny that there aren't, but all the people that I've dealt with who've been refused treatment haven't come here just for the treatment. They've been here generally for a very long time and just been stuck. The case has been refused, but they haven't left. The Home Office hasn't removed them. People are just here and they're destitute and they're unwell. They haven't come here just for the treatment. I think that's the myth, is that people have come here just to abuse the NHS.
There aren't public health tourists.
No. The government's own figures say that it's a negligible amount of a negligible cost to the NHS. That's the government's own review into it. It's very hard to get proper data on it, of course, but from what we understand, it really just isn't an issue. It's massively hammed up by people who have an agenda, and it's easy to point to a single case that was very expensive and insinuate that that's the norm throughout the system, and that's why NHS is failing. But it's just not the case. A couple of comments maybe on overseas visitors managers, which maybe are interesting as well, are that there have been freedom of information requests looking at the cost of employing overseas visitor managers and comparing that to the amount recouped by the hospitals. Unfortunately, this actually hasn't been published, but from what I understand, many trusts have been shown to spend more on employing these people than they're getting back. So they're costing the hospitals more just by going through this process, and that's not even considering the public health implications, which will be costly as well. And the other thing is, I think there's quite a lot of reports from within hospitals and trusts that, I'm not sure where these incentives are coming from for these people, but they're coming at times when they know there won't be clinicians around in the wards. They're coming kind of when there won't be ward rounds where nurses might be on their break, and going and speaking to patients kind of often when they're actually in a vulnerable position. They're not really ready to be having those conversations. So the practices they're using are kind of concerning as well. And yeah, we should be worried about that. one thing I was thinking about when we're talking about urgent and immediate and necessary care is, and I've talked about this before with some colleagues, that basically you could frame any kind of medical care as being urgent, right? Like, why else are we doing kind of medical interventions if they're not necessary in the next kind of 6 months? I don't know from a legal point of view how that would stand up. But
no, I would agree, and I'd argue that to be the case. I think the practice at the moment is that the hospitals, their lawyers are trying to say that unless if treatment's not needed as an emergency, so that they're using emergency equals immediate, necessary or urgent, but it doesn't. Emergency is needed as an emergency, and that's quite different from the definitions. So, if it's an emergency, of course they can go to A&E and get their treatment, but it doesn't have to be an emergency. It just needs to be something that they need to stop their condition deteriorating. So I think there's the misunderstanding of what treatment should be. But arguably, yes, treatment should. Again, with this dialysis case, they were saying, well, the dialysis is elective, so therefore it's elective. It's by choice. It's therefore not immediate, necessary, or urgent. And of course, that's not the legal definition. So I think, although while struggling before I had the advice from the nephrologist, I was, arguably, although you're saying it's not immediate, necessary, or urgent, you're actually not properly interpreting what that means. And yes, so often a patient will be refused the blood tests or the MRI scans because they're not treated as being urgent or necessary. But surely, how can you tell if treatment is urgent or necessary without unless you do these diagnostic tests?